Dear colleagues, this is another case of Yamane scleral fixation on a glaucoma closed angle patient. This technique is the best technique, I think, for scleral fixation in a glaucoma patient. Having the less scleral inflammation, you don't need to open the conjunctiva or the sclera to have sutures. This is a sutureless procedure, and it's very easy to do, and you do it in a short time, so inflammation post-op it's kept to the minimum. Having the IOL fixated in the space behind the iris in the glaucoma patient, when you have no capsular support, instead of using a anterior chamber IOL that can destroy the angle even more and raise the IOP, this scleral fixation 3-piece IOL by Yamane's technique in glaucoma patient, I think this is the best way to approach these cases. The first haptic was easily placed into the needle shaft, and the second one I was trying to see if using the iris stroma it's easier to bend the haptic backwards and to place it into the needle. But as you can see, the iris stroma is very easy to push, and the best way to bend over the IOL haptic is a straight, sturdy platform that is the needle shaft, and that's easy to place the trocar, the haptic into the needle and externalize it, and then using the Grishaber forceps and a hot spatula, I place I make a bulb into the end of the IOL haptic, tack that underneath the conjunctiva, underneath the tenon, pushing it down into the sclera, and that's pretty much the end of the case. It's very easy then to wash out the viscoelastic from the anterior chamber, press down a little bit the iris to break the anterior synechia, and place an air bubble at the end. I like to make a subconj injection with antibiotic and anti-inflammatory agent at the end of the case, checking the vitreous strands if I have some. In this case there are none, into the anterior chamber by triamcinolone, and that's the end of the case. Thank you for your attention. Hope this will help you in your practice also.